and Program Associate at IRETA, and I will be moderating this webinar today. At this time, I would like to go over a few housekeeping items for today's webinar. We would like to encourage you all to participate in today's webinar via two methods. If you have questions for Jim or are experiencing any technical issues, please use either the chat function or the Q&A panel to communicate your questions. Jim is willing to take questions throughout the presentation and will also leave time to answer any remaining questions at the conclusion of the webinar. At that time, I will read aloud any questions that have not been previously addressed. Again, you can submit questions via the chat function or the Q&A panel. Throughout the webinar, all participants will be on mute. Following the webinar, you'll receive two emails. The first will be an email with a link to the evaluation, and the second will have information on how to access your certificate of attendance and continuing education certificates through your MyIRETA account. This webinar has been approved for 1.5 PCB and/or NADAC credits. You can also request a general certificate of attendance. Certificates may take up to 48 hours to appear in your profile, so we ask for your patience. I will go over all of this again at the conclusion of the webinar. At this time, we will go through 3 poll questions. We like to get a picture of the demographics of those in attendance, and there are no wrong answers. I'm going to go ahead and open the poll. So these questions should now have appeared on your screen as an interactive poll. I'll give everybody a few minutes to make your selections, and I will let you know when there's about 10 seconds left. Okay, and it appears that mostly everyone has answered. I'm going to go ahead and share the results with everyone. So for the first question, what is your current professional role? We had a majority of the people list themselves as counselor, therapist, social workers. For the second question, which field do you represent? We have a majority of people who, if you have the people that actually answered, the majority of people chose mental health. And for the last question, how would you rate your understanding of SBIRT? We have the majority of, well, we have a tie between I have a basic understanding and I have a good understanding. So thank you all so much for participating in the poll. We'll be recording today's webinar, and at this time we will begin the recording. I would now like to introduce our presenter today, Jim Winkle. Jim has trained hundreds of healthcare professionals how to perform and implement SBIRT, screening, brief intervention, referral to treatment, in clinic settings. As the creator behind the SBIRTOregon.org website and the SBIRT screening app, Jim has designed clinic tools, screening forms, and video demonstrations that have been widely adopted by health professionals around the country. Okay, Jim, if you're ready, I will hand things over to you.
Great. Welcome, everyone. Thanks for taking time out of your busy day to attend this webinar. Hopefully everyone can see my first slide here. And I appreciate that because I myself am guilty of registering for a lot of webinars, but I don't always actually attend them when the time comes because things get in the way. So thank you. So today, let's see if this works here. First of all, I have no disclosures. None that I know of is paying for my student loans. And then my background, why am I giving this presentation? I do have a pretty long history with SBIRT implementation. John Munch is a family medicine practitioner and principal investigator of two SAMHSA grants at Oregon Health and Science University. First one was in 2008. He hired me as a project director for both of them. We ended up creating a 4-hour training curriculum. We trained a lot of residents and faculty, and then we implemented SBIRT into 7 clinics at the time. And we quickly found out that it takes a lot more than just training people in a controlled setting if you want to implement a new workflow in a clinic. So we ended up working with these clinics to create EHR tools. We trained all sorts of staff. We did this in not just primary care, but pediatrics, women's health clinics. I even did some trainings for emergency rooms. So that was until 2017. And then after that, I'm continuing to consult in SBIRT. So I have a vast background in SBIRT implementation. My experience with harm reduction has really been just the last couple of years. And that has been mostly going to harm reduction conferences, opioid conferences, watching webinars given by the likes of Susan Collins at the University of Washington, going over materials from the Harm Reduction Coalition, speaking to people in recovery who used to inject drugs or have a substance use disorder and have them tell me their stories on their pathway to recovery. So I do not come to this presentation pretending to be an expert in harm reduction, but I have learned enough to where I feel like there is a gap in knowledge that I'll make the case for here, and how I think SBIRT is lacking in a harm reduction philosophy, and how a harm reduction approach could really improve, or has promise at least, to improve how SBIRT reaches folks with substance use disorders. So that said, I hope I sound legitimate enough to give this presentation. And before we get to the outline or the learning objectives, let's start with an attention getter here. This article came out a couple months ago, the Journal of Addiction, and the researchers here wanted to see if documentation of a brief intervention was associated with treatment for alcohol use disorder. And this was in the VA, so they had access to hundreds of thousands of patient records. So they did this over 4 years. That's what they looked back on. And they wanted to see, of those patients who screened positive, because it's the VA policy to, I think, use the Audit C as a screening tool, and they screen everyone once a year. Of those who are positive, who got a documented brief intervention, who didn't, and then between the two, who was more likely to, at some point within the next year, receive treatment for an alcohol use disorder. And the result was surprising. Unfortunately, if someone had a documented brief intervention in their patient chart, they actually had a lower likelihood of receiving treatment. This is really disappointing. If you want to look a little bit closer at the numbers here, this is a table that I pulled out from the article. So there's 2 populations they looked at. The first one was everyone overall, so anyone who had unhealthy alcohol use, meaning maybe they were just risky but not had consequences. And then they had folks who had an alcohol use diagnosis in their chart in the past year. So you can see the overall sample, 12% or almost 13% did not have a brief intervention, but they did get treatment. 10%, statistically significant less percent of people who had a documented VI got treatment. And then even worse is when we stratified by folks who actually had a diagnosis of an alcohol use disorder in their chart, they were less likely, as you can see, a ratio of 0.83, to get treatment, to receive treatment if they had a documented brief intervention. This is a huge study. It's hundreds of thousands of subjects. The confidence interval is tight. The statistical significance is really good. So I would call this a wake-up call because of how hard the data is. But we actually kind of were suspicious of this for a while, that SBIRT wasn't doing a very good job helping people who would benefit from treatment receive it. And I say that because we have more evidence that shows that. But maybe what are the takeaways from the study? Well, first of all, if you read the article, brief interventions are defined in the VA as simply giving information and advice. That's a pretty limited definition of a brief intervention. There's nothing about employing motivational interviewing skills or exploring the patient's motivation to change. It was simply giving information and advice. So maybe we can take away from the study that if we implement SBIRT without some sort of guarantee or training that we're doing decent quality brief interventions, are we possibly causing harm? That study seems to show that people actually are less likely to get treatment if we have a brief intervention with them, and so um, that's concerning. And at a minimum, if we were going to conclude something, it seems like traditional referral to treatments, which we deliver through a brief intervention, don't seem to be cutting it. We do not seem to be making much of a difference. And besides the study, if we were to do a thumbnail kind of look at the evidence behind SBIRT in general, like I said, we kind of know that the referral to treatment part of SBIRT doesn't seem to be working. So the United States Preventative Services Task Force, as you probably already know, says there's decent evidence for adults and people who are pregnant to cut back their use, or self-reported reduced use. We don't have yet enough evidence for adolescents to conclude that. But for people with substance use disorders, if they get a referral to treatment in the traditional SBIRT model, not just the study shows not what we want to hear, but there was a pretty good meta-analysis a couple years ago that showed that it didn't work either. So the big picture look at SBIRT shows that we are not helping people with SUDs very much. And if illicit drug use isn't much better, so moderate evidence, this is new. We used to think that there was insufficient evidence for adults, but now the updated recommendation is there's decent evidence that we can have extended periods of abstinence with adults with certain kinds of drugs. So that was good enough to give it a B rating. Current draft for adolescents says there's still insufficient evidence. I don't know of studies specific to people who are pregnant. And then no meta-analysis that I know of for referrals to treatment. So the news isn't any better for illicit drug use. So, meanwhile, we have plenty of folks in this country, as you know, who have substance use disorders. And it appears that they are not being well served by SBIRT. So one study shows at least 10% of us, or at least adults, will experience some consequences from our use in our lives at some point. And of course, it's consequences that define a substance use disorder. It's not just morbidity, it's mortality. So deaths from alcohol are the third leading cause of death in this country. That's almost 3 times as many people die every year than from car accidents. And then injection drug use is on the rise. It's related to the opioid crisis. And now we have 42,000 folks who die each year from opioid overdoses. So there's plenty of need out there for treatment or for harm reduction, as we'll see. Another study that shows how much need there is and what's lacking with SBIRT is in the last 10 years, these deaths of despair you may have read about, and this is specific to non-Hispanic white Americans in midlife in this country, whether it's alcohol-related liver mortality, drug overdose, and suicide, which is linked to substance use. These deaths of despair have really shot up in the last 10 years. So we know that SBIRT is a public health approach, and we do want to really reach those folks who are not yet experiencing a substance use disorder. We reach the folks who we categorize as risky. That's a preventative strategy, and that's great. But as we can see, people with substance use disorders need to be addressed too, and SBIRT doesn't seem to be doing it. So why am I giving this presentation? I think it's important. Some people already know this, researchers for sure, but not everybody, I think, has really recognized that traditional SBIRT isn't really helping folks who have substance use disorders. I know that's kind of a bold statement, but that is the premise of the presentation. And I think it's worth considering an alternative, and that is integrating harm reduction into SBIRT. The possible benefits of that would be, I think, twofold. One would be before someone is ready to abstain, or if they ever choose to abstain from substance use, there are opportunities to reduce their harm from the use. And the traditional SBIRT model, because it's so singularly focused on abstinence, really misses out on opportunities to help patients reduce their harm. And that is important public health strategy. And the other reason why it's important to consider integrating harm reduction is people get to treatment or get to abstinence if they choose that, typically along a pathway. And if we react to someone who scores high enough on an audit or DAS screening tool to suggest they have a substance use disorder by referring them to treatment, it doesn't reflect what most people's pathway to treatment is, which is it's usually over the long term, and it usually begins with engaging with a health professional to reduce their harm so their quality of life improves, and eventually they can forge their own pathway to treatment. So that's kind of a radical interpretation of how we can react to someone, respond to someone who scores high on an alcohol or drug screening tool. But I think it reflects more of the reality of how we get people to treatment who are ready for it. And then the other part of this presentation is when I go to harm reduction conferences or I talk to people in the harm reduction movement and I bring up SBIRT or even motivational interviewing, a lot of the reactions I notice are kind of apprehensive, or they're not, or they have just negative feelings about SBIRT in motivational interviewing. And I think that's kind of based on some misunderstandings, although also reasonable. People may associate SBIRT with always telling people that you have to abstain if you have a substance use disorder, and they have good reason for that because that has been kind of the model. On the other hand, with just some slight adjustments, I think SBIRT can definitely convey a harm reduction philosophy, and motivational interviewing definitely can too. And I'm going to get into that in this presentation. Although, again, I want to remind folks I'm approaching this with some humility. I'm not coming across as a harm reduction expert. I just want to share what I've learned. I want to share the love. So this presentation will assume a few things. I'm not going to go into SBIRT very much. I'm going to assume that people are familiar with SBIRT as far as the basic workflow of it and what it does. And as far as harm reduction, I'm going to assume there's a spectrum of understanding. There's probably some folks on this webinar who have quite a background in it, more than me, and some folks who are kind of new to it, which is what the polling seemed to reflect at the beginning of this. I don't represent harm reduction in any official capacity. I am going to focus on patients with substance use disorders because that's where harm reduction can do the most good, and that's where SBIRT currently is not doing the most good, or not seeming to. And I'm going to focus on primary care. This, I think, can apply also to emergency room SBIRT, to inpatient hospital SBIRT, but the focus here will be on primary care. So finally, the outline. What are we going to cover? It's important first, if we're going to talk about harm reduction, to understand the perspective and the lived experience a little bit of someone with a substance use disorder who is presenting to a medical setting, especially the emergency room if they inject drugs, or if they have an alcohol use disorder when they show up to primary care. Stigma, as we will see, plays a huge role, and I think understanding stigma, being aware of stigma, lays the foundation of why harm reduction is an important approach when we do this. So we're going to talk about stigma, and then I'm going to describe what the harm reduction philosophy is as I understand it. And then to give people something concrete to work with, because after all, we're not talking about an hour-long session we have with the client. I'm going to focus on primary care, and that means people, if you work in primary care or you train people in primary care, probably have 3 to 5 minutes or so to talk about this during a 15-minute visit. So I'm going to try to give you something concrete to work with, a model of how we can do a brief intervention that is what I call harm reduction informed. And then the referral to treatment, I'm not going to suggest we tailor it. I'm going to suggest, as other people have, we kind of do away with it altogether or radically redefine it. And that is because when we refer to someone to treatment, because of their score on a screening tool or because of what they shared with us, it doesn't do any good. That's going to be the premise. So that's the outline. I want to acknowledge that these slides I put together, some I have created before and some come from other people. So deep gratitude to Susan Collins at the Harm Reduction Research Treatment Center at the University of Washington. She's great. Watched her webinars and seen her in person. I used some of her slides. Some of these slides come from slides I've created in the SBIRT Oregon training curriculum on the website. And then the Oregon Health Authority has a project underway where we focus on reducing morbidity and mortality associated with injection drug use. So slides I've made for that project are in here. And then there's plenty of slides I created for this as original content. So beginning with building the foundation of why harm reduction is important, we have to understand where patients with substance use disorders are coming from. And I quote this study because I thought it was surprising. This study took a large number of people and gave them a lot of questionnaires on all sorts of things, including consequences, or what this study at the time defined as dependence on substance use, this DSM-4 definitions. So it diagnosed people with dependence or not, but it also asked them, as you can see, about a lot of social economic demographics. So it asked folks lifetime history of violence in your family, mental health diagnoses, how often have you visited a health professional, what is your gender and age, income, and it took all these things and it wanted to find out of those people who are probably dependent on a substance, which of the other factors, the variables, are the most highly correlated being dependent on a substance. And the conclusion was stigmatization. So feeling stigmatized by society, by your friends, internalizing stigma was the #1 variable with folks who have dependence on a substance. That's important to keep in mind here because it plays a huge role in why folks with substance use disorders avoid primary care and emergency medicine. And when they do present, if they're brave enough to present, why they might not disclose their drug use and why they might not show up till they absolutely have to because their skin infections are so bad. We're going to talk about stigma, and of course there's different definitions, but it basically means how we can relate power and control over people by judging them, and it has to do with loss of status. It's stigma is based on attributes. So substance use obviously is a big one, but we can also have stigma towards people based on their race or their class, or if they're homeless or not, if they have a mental health diagnosis. And when we discriminate, and that's based on how as a provider we might behave differently or provide different care based on our stigma, that is actualized as discrimination. So discrimination is an actualization of stigma. So specifically with drug addiction, unfortunately, surveys show that most Americans, and this is one way stigma is conveyed from society, is that they don't really like folks who are addicted to drugs. They don't want to be socially connected to them. They don't think they're worthy necessarily of assistance, and they kind of regard them as dangerous. This is important because people who are addicted to drugs sense that. They know that. They are people too, and we sense whether from walking by people on the street or engaging with anyone in a setting, we can tell when people have stigma towards us. The problem is that can become internalized, and that becomes an important factor too. And if someone who is addicted to drugs or alcohol has internalized stigma, they're less likely to seek health care. And if they do, they're less likely to disclose use, so they won't get help to reduce their harm. They're less likely to get treatment. And the paradox is that it comes a lot once we internalize stigma, our self-worth goes down, our self-esteem goes down, and then the irony is we can use substances as a way of escaping or coping with that internalized stigma. And of course, that just makes it worse. And the psychological harm that comes from stigma has been measured to be greater than actually having a disorder itself. The other way, of course, stigma happens with folks who are addicted to drugs is it comes from providers, unfortunately. Studies show it's pretty widespread in that it's more stigmatized than other things patients present with, like a mental health diagnosis or obesity. Patients with substance use disorders tend to face the highest stigma from providers. And what does that mean? Studies show that providers, if they have stigma, will behave differently towards folks with substance use disorders. So they're less likely to help them reduce their harm. Unfortunately, they're even less likely to give antiretroviral treatment to folks who are HIV positive. they won't engage with these patients as much, and they have less empathy. So this is why when we train providers in SBIRT, we need to talk about stigma because unlike yourself, if you're attending this webinar, you probably have explored this and probably empathize with people with substance use disorders more than most. But as we reach out and try to implement SBIRT, we need to understand how most providers probably start out with a baseline of stigma towards this population. And it comes from generalizations. So providers view patients with substance use disorders as probably not going to be honest with them, which, as we'll see, they have good reason why they may not disclose drug use with a provider. We generalize about them how they overuse resources and that they're not likely to be vested in their own health or adhere to a treatment plan, and they just abuse the system. These are unfair generalizations and not very understanding of why this population may behave and think like they do. I wanted to pull, so one way to fight stigma is to build empathy by kind of sharing the perspective of people who inject drugs, people with substance use disorders when they do present. So I'm going to pull some focus group quotes here, which are from peer-reviewed studies. You're free to use them yourself. So this anonymous patient said, yeah, there's a stigma attached to it. It's different than if you have cancer or heart disease, because you can say, well, that's not my fault. That's in my genes. But the world looks at substance use as this is your fault. People are sensitive to feeling accused of bringing this upon themselves. Donna says, you know, the minute you find out you inject drugs, the doctors, you can see it right in their face. Change their whole attitude. They don't want to help you. I hate it. I hate telling the doctor I use drugs. Their whole attitude changes. So nonverbal communication of stigma still conveys stigma. Patients with substance use disorders report being very sensitive to it. They can perceive subtle changes in behavior from medical professionals when they disclose it. I found this in the literature a lot. There's just a lot of non-verbal stigma communication. So people who inject drugs, PWID, focus groups, there's a lot of comments about feeling looked down on, look at us like we're garbage, they give us naughty looks. And a lot of this comes when they present to the emergency room. So this impacts patients. They're more likely, if they perceive stigma, they're more likely to conceal their use, because who wants to disclose something that is stigmatizing? They don't feel like they have good rapport with their provider, obviously. They're not likely or less likely to accept treatment or come back for follow-up. So it has an impact on behavior. Why do people delay care? A lot of folks who present to the ER with bad skin or bone or blood infections from injection drug use is because they wait till they absolutely have to go. In fact, Melissa here says she'd literally rather die than face how they're treated when they show up, and that is sad. When it comes down to it, a lot of times I need medical attention, I keep putting it off because I don't want to face the embarrassment. So again, Stacy, same theme here. And then if your patient, you know, if providers don't feel like their patients are honest with them about their drug use or their addiction, well, it might be because these patients are trying to receive higher quality care because they notice or they hear from their friends that if they do disclose it, everything changes. And suddenly the provider focuses on their drug use, even if they come in with a complaint that's not related. So I don't want to tell them, says Donna, that I'm a drug user because they'll think something's really wrong with me. They won't keep my appointments, says Richard. She would care less. She wouldn't work with me like she would with someone who didn't do drugs. There's just some things I wouldn't tell a doctor, says Aaron. More reasons why patients may not disclose, especially injection drug use or a substance use disorder. Maybe their insurance will be threatened or their access to it. Maybe they'll be reported to the police if their substance use disorder has to do with an illicit drug. And a lot of folks just aren't ready to admit to themselves that they do something as stigmatized as inject drugs or they have an addiction to alcohol. Just a couple more quotes here. I wanted to find a similar focus group with clinicians or nurses in an ER or providers in primary care, because If stigma is that widespread, it's a sign that it's not just a few bad apples of people who have poor attitudes. It probably is a sign that there's something structural or environmental about the medical workplace that makes it challenging to work with people who are addicted to drugs. I couldn't find any focus groups on that. It may not be something that clinicians want to admit, but there are some focus groups of people who inject drugs who recognize that maybe we aren't the easiest population to work with sometimes. So this person said he walked 30 or 40 blocks, so he had transportation barriers. I went to 3 or 4 different places, finally went to someone who could help him, and then they just started interrogating him about your double doctoring or you're this and you're that. So they don't always present in the best of moods. Another quote here. So Meghan says, if I do disclose my use, they won't give me any pain medication. They assume I have an opioid problem. So just some quotes there to help providers understand where their patients with substance use disorders may be coming from. The good news is research shows that we can mitigate stigma, and this is an important part of harm reduction if we want to teach this philosophy. And the factors are the more knowledge we have about substance use disorders or addiction medicine, the less likely providers will have stigma towards this population. If we don't believe, if we don't attribute someone's disorder to them, we are less likely to have stigma. If we have personal experience working with people who have substance use disorders or inject drugs, we have less stigma. And then lastly, and that's what this presentation focuses on, is if we train and educate these folks, there's evidence that shows they have more positive attitudes and knowledge towards people with substance use disorders. So that's the good news. And if we're teaching this to providers, it basically comes down to we should challenge people's notions that an individual is responsible for causing their substance use disorder or that they can control it. And then we can use language that doesn't perpetuate the stigma. So when it comes to causing a substance use disorder and attributing that to an individual, we all know factors that are associated with what we're trying to mitigate here. So if we use the problem tree as an analogy, risky substance use and substance use disorder being the behaviors that we're trying to reduce, and the outcomes, the negative outcomes are on top there in the branches. We know that the roots, research shows over and over again that coming from poverty, coming from trauma, being in a family where there's abuse, being genetically predisposed, there's a lot of things that are very strongly correlated with a higher likelihood of having a substance use disorder. This is important to keep in mind. It's important to convey and remind people as we train them in SBIRT. And of course, if we want to talk about the cause of substance use disorders, especially with opioid use disorders, let's don't forget the health industry ourselves. So as we all know by now, a lot of money was spent by a lot of smart people to market addictive medicine to people who had pain. And it was done irresponsibly. And we all know the stories of how someone was overprescribed Vicodin, perhaps for a pulled tooth, and then they became addicted to it, and they were cut off, and then they moved to heroin. So a lot of this, when we talk about cause, a lot of this came from the healthcare industry, unfortunately. And then control, our understanding of addiction shows that our brains are changed when we have a substance use disorder, and that means our ability to exert self-control is impaired. So the very definition of having a substance use disorder, as our current understanding defines it, is the impairment of self-control. Oftentimes, people with substance use disorders do not feel normal if they aren't using. So on one hand, I think harm reduction advocates aren't big fans of this approach. They call this the disease model. And as we'll see later, they don't really agree with the disease model of substance use disorder. On the other hand, if we do understand it as disease, that can help alleviate some of the stigma we might have towards this population, because we understand how the brain is changed when we have a substance use disorder. And this understanding is mainstream. So the Surgeon General's report defines substance use disorders as a chronic brain disease. and that the changes in the brain persist long after the substance use stops. So this can be helpful for some people to better understand why someone isn't able to control their use. And the other thing I like to remind too when we do trainings is, we all have behaviors on a spectrum that aren't really good for us, or we feel ambivalent about changing. And one common way, of course, is how often we look or engage with our smartphones, even though there's a couple studies out now in peer-reviewed journals that show use of smartphones is associated with some bad things like lower intelligence and cognitive capacity, not sleeping well, even tumors. Your chance of brain cancer goes up the more use of your cell phone. So I bring this up because just remember, we all have behaviors that we struggle with changing, perhaps. Um, so it helps us empathize with people who maybe we don't understand why they aren't changing their behavior. And of course, we should use the stages of change model to understand. Someone with a substance use disorder may be pre-contemplative about the feeling of if they should receive treatment for it or not. We should understand that people typically move sequentially through these stages. So again, more understanding about control will help us mitigate stigma. Lastly, when I talk about stigma, and I'm going to move on here, is that our words are important. Research shows that the kind of language we use can perpetuate or alleviate stigma. So what can we do as we train providers in SBIRT? Let's try to use and encourage the use of language that is person first and it's not sensational. So what are examples of that? The White House in 2016 issued a report with some suggestions about this. So we can mitigate stigma by, instead of saying injection drug users, hopefully by now we know we can say people who inject drugs, so the people part is first. There are also people who may go bowling, or people who like certain movies, and people who have friends, and then people are complex. Injecting drugs is just one thing that they do. They're not defined by it. We know now that words like abuse and dependence, which have negative connotations, they were in the DSM-4. We now say substance use disorder, and that's good. That is a more accurate and less stigmatizing phrase. We don't call people abusers or addicts or even alcoholics anymore. We're not supposed to. It is better to say a person with a substance use disorder. They are a person first, substance use disorder after that. Clean and sober implies that someone's dirty if they're not sober. So it's maybe better to say person in recovery. And then I've heard this from some people at needle exchange facilities where, if someone has used a needle and then we call it dirty, it implies that the person who used that needle is dirty themselves. So maybe it's better to say used or new needles. Dirty is a negative word associated with a positive urine drug screen. So saying positive or negative is a little better. And then you may have noticed that folks are starting to move away from MAT to describe things like buprenorphine because it is a medication, that's accurate, but it doesn't have to assist some other kind of treatment like counseling. It may be more effective with counseling, but it is effective on its own. And so some people are trying to instead say medication for opioid use disorder. I don't know if the acronym MOD or MODE is going to catch on, but it is more accurate to say medication for opioid use disorder. Instead of high risk, we could say individuals at risk of acquiring. So language is important. As we implement SBIRT, as we train other folks on how to do it, using this language helps mitigate stigma. Just a couple more quotes here. Speaking of language, so this person said, when I see my family doctor, he comes to the door, he's got a smile on his face, and he says, how are you doing, Bob? As opposed to going to the ER and it's like, what's the problem? I'm not a person, I'm an object. So people with substance use disorders or inject drugs are more satisfied with the visits when they're treated as equals, worthy of dignity. And then the last quote I'll share is a positive one too, because this person overdosed, they woke up later in intensive care, and then one of the social workers there really came through and connected with this patient. She was committed to building rapport. And this person was suicidal, but then later got their head back together, their life back together, and they credit that social worker with essentially saving their life because they felt cared for. So don't underestimate the power of building rapport with folks who may or may not be ready to stop using their substance. You may be helping them forge a pathway on their own to reducing their harm or stop using. Okay, so that is a very quick overview of stigma. It lays the foundation for harm reduction. And we're going to talk about that a little bit. And then we're going to talk about specifically how it can form the SBIRT model. So harm reduction has been around for a while, and sometimes it's described as a philosophy or a framework or an attitude. It technically is a series of interventions too, if the interventions aim at reducing negative effects without focusing on extinguishing the behavior that is associated with negative consequences. It's been around a little while. It's been applied to other things. Of course, today we're going to talk specifically about substance use. On a policy level, harm reduction, I think a good example of that is probably decriminalization of drug laws, like when states legalize or decriminalize cannabis, for example. I think that's an example of a policy level harm reduction. Population level, I like to think of Mothers Against Drunk Driving. If they're still around, if you may remember, the message of Mothers Against Drunk Driving was not to stop using alcohol. It was, if you do drink, don't get into a car and drive. That's a good example of harm reduction on a population level. Community level, of course, needle exchange services are great. A great example of community level harm reduction. But today we're going to focus on the individual level, because in a clinic setting, one-on-one with a provider or behavioral health specialist, that's also how harm reduction can be employed. It is not the same as just tolerating substance use. A lot of people who have objections to harm reduction and who don't have a good understanding of it may believe that it just means we just sit back and quote unquote tolerate their use, but it actually is proactive. It works with the patient, it shares information with the patient and helps them come up with their own goals on how to reduce harm, including for some patients ready to try abstinence. Necessarily a fixed set of rules or approaches, is more of an attitude. So if we take a harm reduction approach to someone with a substance use disorder, that means we are not prioritizing or taking an abstinence first approach, because that assumes that is the goal of the patient or should be the goal of the patient. Instead, we recognize abstinence as just one of many options. Abstinence is a great way of reducing harm. Someone abstains from using a drug that is associated with negative consequences. Their harm will very likely go down, but it's not the only way. So if we take a harm reduction approach and we recognize there's lots of ways people can reduce their harm opposed from giving up use entirely, we immediately broaden the spectrum of people we can engage with and help. This is where SBIRT can help, because the medical setting, primary care, emergency medicine, is a precious opportunity to reach folks who otherwise may not know that they have a substance use disorder, or have never heard from a professional or brainstorm with them strategies on how to deal with it. But they do show up because they have a sore throat or a sprained ankle or whatever, and we should take advantage of that opportunity to perform harm reduction. So if we give up an abstinence first approach and just recognize it as one of many options, immediately we can relate to a bunch of folks. And the whole harm reduction philosophy, I think, can be summed up by this phrase, which you've probably heard: meeting the patient where they're at. That is harm reduction in its core. Rather than imposing on them a recommendation that they either cut back their use or abstain, we put that aside and we instead try to find out, where are they at? What would they like to change about their use? Some other beliefs. Harm reduction recognizes that people use substances for positive reasons. Important to recognize that, because when you do, you convey the message that you are a fellow human being and understand why someone might engage in a behavior that has negative consequences, because it also has positive consequences in the short term. So there are both pros and cons to substance use. It's here to stay. Substance use has been around for millennia. We're probably not going to eradicate it in our 15-minute primary care visit, so why waste time trying to do that? It's complex. Uh, People who use substances or have a substance use disorder, they are more than just the substance use. Um, it doesn't define the client, meaning people have complex lives and their substance use disorder is just part of that life. They're not necessarily defined by it. And that it also exists in a social context. People in the harm reduction movement are big on this because, rightly so, they recognize that over time we keep developing our understanding of what a substance use disorder is. Look at the DSM progression from the 4 to the 5, or even before that. Look at the progression of how we understand it as a brain disorder. We didn't used to look at it that way. So essentially, substance use or substance use disorders is a social construction. Harm reduction recognizes that. And so they are apprehensive about putting a lot of faith into the latest DSM-5 understanding or how we categorize substance use. In theory, there's theory and practice. In theory, it's pretty simple to define harm reduction. If we are compassionate, hopefully everyone is, but in addition to that compassion, we are also pragmatic. We meet the patient where they're at. Those two things together, that's the harm reduction philosophy, essentially. Now, if we're going to put that into work on the ground in real life with someone in our exam room, we use that philosophy, we can help the patient reduce harm. And if they reduce harm, their quality of life will improve. And that is the pathway. If they choose to accept treatment and abstain from use, that is typically the pathway that will lead to that. So by giving up, convincing someone to abstain, and instead just engaging them in a way that reduces their harm so their quality of life improves, over time, people can forge their own pathways to recovery or to accepting treatment. This is usually how it works. And I think the traditional SBIRT model does not recognize that. It encourages providers to recommend referral to treatment if someone has a substance use disorder. And it's good that they do that through a brief intervention, through motivational interviewing, but it still is a recommendation that comes from the provider. And that means it is provider-based, provider-centered, provider-driven. That is different than patient-driven, as we'll see. Traditional SBIRT has abstinence as the ultimate goal. Abstinence is good because it is one way to reduce harm. Harm reduction recognizes that. Its ultimate goal is to reduce the harm, recognizing that abstinence is one of many ways to do that. So again, we're broadening the scope of people we can help by prioritizing reducing harm rather than just one way to reduce harm. When we are harm reduction advocates, we recognize that substance use and associated problems are not a one-to-one ratio, meaning that and research shows this, that the consequences associated with substance use are not just from the use, but also affected by variables like race and class and education and gender and sexual orientation. It is within the context of society. So a white male who has a professional job and is highly educated can get away with more likely to get away with less consequences from heavy substance use than perhaps someone who is homeless or a person of color and faces disproportionate punishment from the legal system. So harm reduction recognizes that our consequences associated with a substance use disorder are not just from the substance itself, it's within the context of who we are and what the dominant culture is in society. Traditional SBIRT prescribes treatment. You have a score on this screening tool, so I am prescribing a referral to treatment. Harm reduction says it's not really our role to do that. What we can do as a health professional is offer knowledge, offer science, information to the patient, and then they can assess their own risk of harm, and that's very different. So when we prescribe treatment, it kind of implies that we know what's best. No matter what your context in your society or what's going on in your life, I'm prescribing that you should abstain. That implies that I know what's best for you. Of course, the patient knows their own lives better. We are all experts on our own behavior in our context and society. Harm reduction recognizes that. So traditional SBIRT again believes abstinence is the only or best way forward once someone discloses or you diagnose someone or with a probable disorder. But harm reduction recognizes that actually the best path forward for someone with a substance use disorder is to keep them alive and reduce their harm. That's how we move forward with someone who is newly diagnosed or has a probable substance use disorder. Keep them alive, we help them reduce their harm in ways that they're willing to do, and then they may choose abstinence or treatment on their own. More differences here. More characteristics, and some of these are already part of the traditional SBIRT approach, but I just want to emphasize them because they are part of harm reduction too. We always respect our patients' autonomy. As far as I know, clinicians are not held accountable by any metric for their patients' substance use. Hope that's the case. I haven't come like it. We are not held accountable if you're a clinician, if your patient reduces their use or abstains or not. Our goal is to deliver with high fidelity, as much fidelity as we can, a quality brief intervention, and hopefully it's harm reduction informed, and then we leave it at that. We have to because we have to move on with our patient schedule, and that's how behavior change works. Is we, the analogy used in motivational interviewing is plant a seed. We plant a seed in the patient's brain. It's up to them, or we water that seed, and it's up to them to decide what to do with that. People have their own goals and values, which may or may not meet what we would like for them as a healthcare perspective. We have to be comfortable with ambivalence. People rarely have concrete ideas about what to do about their use at first. And then a lot of times as a health professional, you are the expert if it's a healthcare visit. But when we start to talk about the patient's behavior with their permission, the role switch. Suddenly they become the expert, and we have to be comfortable with that. And then of course it helps to be empathetic, non-judgmental, respectful. So this comes from Susan Collins, who saw this note pasted up or taped to the inside of a bathroom stall, I think, or on the wall. She took a photo of it because it was taken from an addiction medicine clinic. And it was a note that said, our clients are very sick and they often lie to us. And then someone wrote on the bottom, and sometimes they tell the truth. So she pointed this out because it kind of demonstrates three things. First, the disease model. Our clients are very sick. And I bet whoever posted this up on the wall was trying to be helpful by reminding folks that if your patient lies to you, it's because they have a disease that infects their brain. Maybe that helps people empathize with someone with substance use disorder, but people in harm reduction movement really don't like to reinforce that disease model. Maybe it is a brain disorder, maybe it isn't. Our understanding of addiction continues to evolve. And then the moral model, they often lie to us. It's kind of a moral judgment on substance use disorders. But at the bottom there, recognizing that they also sometimes tell the truth is a more holistic understanding of a person with a substance use disorder. They are not defined by the disorder and why they might not disclose to you in all honesty their substance use. As we've seen, there's good reason why they didn't do that. So recognizing that holistic idea of a person is moving towards harm reduction. Now, when I talk to providers, or if you talk to providers, I do like to acknowledge that this may make some sense, harm reduction approach. It may seem very radical. And this is a quote from an article that interviewed a bunch of people who worked at a very harm reduction informed HIV clinic. And it concluded, I drew the sense of the conclusion that, it's important for providers to know that they may feel moral ambiguity about using a harm reduction philosophy, since they are essentially supporting individuals in health behaviors that are likely to result in negative health outcomes. So I like to open it up for discussion, not necessarily during the webinar here, but when I talk to providers, does this seem morally ambiguous to you? Does this fit into the medical model? I believe it does. I think there's good reason why it should. But again, we don't want to impose on providers, you must do this. We're trying to show them how they can better serve their patients by adopting a harm reduction approach. So back to our outline, that is a quick and dirty kind of summary of harm reduction. What's more important is, well, how do we deliver SBIRT in a harm reduction informed way? And I think there's two ways to do it. Tailoring the brief intervention. And I say tailor because there's really just a couple of things about a very commonly used model of a brief intervention that we can change to make it harm reduction informed. I really think it's pretty simple. And then I'll talk about how when a referral to treatment, I don't think there's a really good way to just tailor it. I think it should be done with entirely or redefined or even replaced. And I'm not the only one, as we'll see, who is suggesting this. But I think we really need to radically change the referral to treatment part. But the brief intervention, we're almost there already. We just need a few tweaks, and we're going to look at that. And just to give some context, remember, especially with primary care, we're not talking to psychologists who have an hour to talk to someone with a substance use disorder. SBIRT mostly is imposed, and I say imposed, from policymakers, funders, on primary care providers who are already inundated with a bunch of preventative services that they're supposed to be doing, trying to convince to do by a bunch of people with their own pet projects like me. When I come in to do a training, it's do SBIRT. That's my little thing among the other things you have to do. But they aren't given any more time to do it. A lot of times they aren't given more money to do it. So recognize whenever we're trying to do SBIRT, empathize with the provider, even though there's lots of room for improvement on how they can address substance use and substance use disorders. They have real limitations with their time. So understand that patients often come in with multiple complaints, so providers feel they have to squeeze in SBIRT. No one really makes an appointment in primary care because they just are curious and they want to talk about their substance use. It's almost always because they come in with a complaint that may be or may not be related. So clinicians probably have 3 to 5 minutes to talk about this, and they have barriers. Time, obviously, they're afraid of talking about substance use because they might open up a Pandora's box, what they call it, of issues that they don't have time for. They don't feel like they got trained. It's hard to train primary care providers, by the way. Their time is money. You have to pull them out of their patient schedules to train them. And if you're lucky, you might get 2 hours, which is usually what I get. Even if they know how to do a harm reduction form model of SBIRT, who's to say that there are resources available for patients who are ready for treatment? So why bother if I can't even refer anyone to anywhere? We may have a social worker on staff or a licensed clinical counselor or someone else, but they may not be available. And of course, once we train everyone in this, then they leave. Turnover process. So there's lots of barriers here. There's remedies to their barriers, and this is important to convey. Providers are not expected to be a counselor when they do SBIRT. We recognize they get 3 to 5 minutes to do it, and there's evidence that shows that can be effective. They don't have to be masters of motivational interviewing. People with substance use disorders probably don't want you to solve their problem. They may not be really happy to open up a Pandora's box of issues because they're not so happy disclosing their substance use typically. You don't have to be someone who goes to a 4-day training in motivational interviewing to be impactful. Short trainings can impact provider behavior. Most of people with substance use disorders are not ready to accept a referral to treatment. So if you have a lack of resources in your community, which I'm sure you do, don't worry about it so much. Still bring this up in a harm reduction informed way because most of your clients are not ready just based on your brief intervention to go get treatment. This is an important provider skill. We shouldn't rely on behavioral health folks in our clinics to do this. They're great as a resource. They typically have more time. They probably have more of a background and knowledge in this. But this is an essential primary care provider skill. You can use motivational interviewing the same way as we do with substance use towards diet, exercise, adhering to a medication plan. It's just a fundamental skill that you should learn. And then having a clinic champion helps. So what can we do? Folks with substance use disorders, we can screen, we can treat their complaints, we can offer harm reduction. People who inject drugs, we can offer medications, or even if you have an alcohol use disorder, there's evidence medications for that. PrEP is something you can take to prevent getting HIV. We can treat hepatitis C in primary care. We can even treat HIV in primary care. There's a lot of things we can do. We can provide just general care. And by doing this, we can help patients forge their path to recovery. Um, so there's, besides convincing someone with a substance use disorder to get treatment, we can do a lot more in primary care for patients who are not ready to do that. So what is the workflow? It's typically starts at reception, maybe with a brief screen, and then when you're roomed, you get a full screen as an adult, or if you're an adolescent, you get a full screen. So using this as kind of like a model here, you might start with the single question brief screen. Maybe you screen everyone with an audit C, that's fine. These screening tools are fine with harm reduction. They recognize, people in harm reduction movement recognize tools like the audit and the DAST. I would say, however, that when you use them, you might add that the DAST, for example, does not ask about injection drug use. It doesn't ask about treatment. On our SBIRT Oregon website, we added those questions to our version of the DAST. So you might consider including those questions. The audit, same thing. We added a question at the bottom. Have you ever been in treatment for an alcohol problem? It's not a validated question because I don't know if it's been tested or not, but it's helpful information. There's better tools out there. You know, the assist is a great tool, but it's full of skip patterns. It's long. It's not really practical for primary care in an interview format or paper-based. So we're pretty much stuck with the audit and DAST in primary care. So brief intervention. Whether we are exploring someone's motivation to change, or if we're doing it a referral to treatment, which we'll talk about later, this is how we deliver any kind of discussion about substance use. It should be a brief intervention, and brief interventions have various definitions out there. They should employ principles of motivational interviewing. That's where the evidence base comes for their effectiveness. How do we do that? If we have 3 to 5 minutes, we use models. And the most common model, I think, is a brief negotiated interview. It's been around for a while. It comes from Gail D'Onofrio and some other researchers. It basically just gives a framework for how do we talk about this when we don't have a lot of time. And this, for the most part, is harm reduction approved or informed with a couple caveats. So let's look at the first one. And first, I want to make a Venn diagram because, like I mentioned before, people who talk about harm reduction have kind of skeptical attitudes sometimes about motivational interviewing because they associate it with always starting from a place of how can I get the patient to change, to reduce their use or abstain. That is not part of harm reduction. However, if you talk to motivational interviewing trainers, like I have, they say that's not the case. Yeah, it's been used a lot in the substance use field, and it does start with that premise, but motivational interviewing as a skill in of itself can be used for any kind of behavior change. So someone who's interested in injecting more safely, someone who's interested in drinking alcohol in a safer way, someone who's interested in using clean needles or getting housing or anything, flossing. Motivational interviewing is a patient-centered way to talk about it. So this Venn diagram shows what my understanding of how most of motivational interviewing fits under traditional SBIRT and it fits under harm reduction. Look at all those things that belong to both fields. Things like the OR skills, asking open-ended questions, affirming patient, summarizing patient, honoring patient's autonomy, being empathetic, respectful, eliciting the patient's own values. Most of these things fit in different approaches. So what are the differences? This presentation pretty much hinges on recognizing the difference that is, if we use motivational interviewing to explore a patient's motivation to reach a goal that we came up with as a clinician or behavioral health person, that makes our MI or our brief intervention clinician driven. We came up with a goal, and we are now asking the patient through a brief intervention how ready they are to meet our goal. That is not harm reduction. Harm reduction would say the patient decides what goal they may or may not want, if any, and then we can use motivational interviewing to help that patient explore their motivation to reach their own goal. Doesn't seem like much of a difference, but it is a big difference. And in the traditional SBIRT model implies that we recommend one of two things. I recommend you reduce your use, or I recommend you abstain based on your score in the screening tool. And if we do that, if we start with that premise, even if we use good MI, we are not making it harm reduction informed. We are conveying and implying judgment. And even if you do it in a very nice motivational interviewing method, the patient still feels like you have something in mind for me, and I may not be ready to meet your goal. So recognize, though, that for the most part, motivational interviewing fits both bills. So how can we change the brief intervention to be HR informed? Well, using the brief negotiated interview model, the first step is to raise a subject. And we always ask permission. That's great. The thing in red here is what I'm offering as an addition or a tweak to the brief intervention model. So thanks for coming in today. We've talked about your acid reflux. And before you leave, I noticed here that you filled out one of our alcohol and drug screening tools. Is it okay if we talk about that? Is it okay if I go over it with you? So asking permission sends the message that I want to embark on a conversation together rather than I'm going to be telling you what I think you should do. That's already part of this model, and that's great. However, then I would add after that, once you get permission, be transparent about your role. Meaning, don't assume that your patient understands what your role is. They may think if they have injection drug use or they have a substance use disorder, that your role is to fix them. Your role is to convince them to abstain or get treatment. And if you want to take on a harm reduction philosophy, you could set the stage by being transparent about your role. And I would consider a couple sentences like this. Thank you for giving me permission to discuss your substance use. Just so you know, I'm not going to advise you or ask you to stop or cut down your use in any way that you don't want to. Instead, my focus is to understand what your goals are, help you with those goals, help you assess the relative risks of your behavior so you can make your own informed decisions about your substance use. Ultimately, I want to help you improve your quality of life on your own terms and on your own timeline. How does that sound to you? So conveying that message really sets the stage for the conversation you're going to embark on. It'll probably be surprising to the patient who, for some reason, may expect that we'll talk about their substance use because you have judgments of what they should do. So be transparent about your role. The last step of this, of course, is eliciting the patient's own description of their use, including perceived and pros and cons. So this is part of the original model here. This is important because the screening tools give you the patient in their own words describe their use. Recognize that they have pros as well as cons to the use, or maybe they have cons. Maybe they don't see any cons at all. They may only see the positive things associated with their use, but ask them about both. So the info you might get is what people they use with, how, when, with whom, the effects it has, how they feel about it. And then just ask them, I'm curious, what do you like about your use? And then I'm also curious what. So that's the first step. The second step is commonly called provide feedback. If we want to be harm reduction informed, I would just change the name of this to begin with, to share information. Because if we're providing feedback, feedback implies I just want to give you an opinion on your behavior. Instead, if we're harm reduction informed, let's share some of the science. Let's share some of our medical knowledge with the patient that informs them about the risks so they can decide what to do, if anything, about their behavior. So the first thing I would do is just change the name of this to share information. And again, most of the stuff under this step, as it already exists, is great. If your patient comes in with a complaint that is related to their substance use, they deserve to know that. I can tell you that one of the things we know is associated with insomnia, for example, that you came in with, or your anxiety or the depression is drinking alcohol. I can also share with you that we know that drinking a certain amount of drinks per week or per day is likely to increase the risk of new health problems or make existing ones worse. It's also okay to express concern. We are not necessarily implying judgment that someone needs to change their behavior by being honest that, when you told me on this form here that you've been in legal trouble or you've had a friend or family member express concern about your substance use, I'm concerned. I'm worried about the consequences you've told me that are associated with your substance use. And then after you've shared this information, ask the patient what they think of the information. I'm curious, what do you think about all this? Right? So it's reinforcing the model that this is a team-based approach to this conversation here. So probably the biggest thing here that I would change, I'm suggesting people change when they deliver a brief intervention, is give up the recommendation or advice. It pretty much is included in most models of a brief intervention. And I would recommend not doing that. And why? Because people with substance use disorders already feel trapped. This is what they tell me. When we are addicted to a substance, we feel like our options are limited, and we don't need yet another entity in our lives telling us what they think we should do, or advising us on what they think we should do, or recommending it. It just kind of reinforces our limited options worldview. And that's what traditional SBIRT typically does is you got two options that I'm recommending to you. I'm going to recommend that you reduce, or if you score high enough, I'm going to recommend you abstain. And that's kind of the end of the story. Um, so when we give advice or recommendations, it does imply judgment because it implies that I know best and you're not doing currently what I think is best. And that risks furthering stigma, which means your patient's less likely to come back and see you because they haven't met your recommendation. And again, if we give that up and we don't offer a formal recommendation or advisement, we are expanding the number of people we can relate to because we just recognize abstinence and reducing use as a number of many options a patient can choose from. So by sharing information, we are helping the patient. By making a formal recommendation or advising them, we are going against a patient-driven harm reduction model. So that's the big change. And I looked up, what is the SAMHSA definition of brief intervention? If we don't formally give advice or recommendation, are we like not meeting some metric or billing code or something? And this definition from SAMHSA mentions brief advice, but it says only if brief interventions last from or 5 minutes or less. That doesn't make sense. So I don't think the definition is very clear about you have to give advice or recommendation as part of an evidence-based brief intervention. If I'm wrong about that, please email me and let me know. I looked at the billing codes definitions, and like billing codes, as you can imagine, they are abstract and don't make a lot of sense, but the description of if we want to bill for a brief intervention doesn't technically say anything about you have to give advice. It's pretty broad language about the brief intervention explores the patient's motivation to change. So it looks like we can still bill for this, although as you probably know, those billing codes for brief interventions are problematic because they require 15 minutes being spent doing the brief intervention, and that is not practical. So these billing codes don't get used very much. When we document a brief intervention in the note, I'm not a medical provider. I'm not sure if it's required or some sort of protocol that we always give quote unquote medical advice to a patient. But one way around that is, this is an example of a note that backs up a brief intervention billing code. And I think if we use the language of, I shared the low risk guidelines, in this example of what the low risk limits of drinking are, that is different than I recommended to the patient or I advised the patient to drink under these guidelines. It's a difference between I'm advising the patient what to do and I'm sharing with the patient what these limits are that the research shows will increase the risk of negative consequences. I think we are serving the patient better by using this kind of language. So that is my big suggestion on share information. Just discard the formal recommendation or advice. The next step is enhanced motivation, or sometimes it's called build readiness. This, for the most part, is great. We've shared information with the patient, and we've asked them what they think. So we should summarize what they think, and we should summarize what we hear their perceived pros and cons are. And then, because we have not given a formal recommendation or any advice, we should then ask what the patient would like to change, if anything. And that's as simple as asking an open-ended question. So now that you've told me what you like about your alcohol use, what you don't like, um, and I've shared with you what I know from the literature on the possible consequences, I'm curious. So over the next few weeks, months, what would you like to see happen for yourself? What do you want to do about your use? Is there anything you'd like to change? Where you want to go from here? These are all good examples of open-ended questions that kind of leave it in the lap of your patient to decide what goal, if any, they are interested in. That makes this, when you replace this open-ended question, when you replace the recommendation with this open-ended question, that's a big step in making a brief intervention harm reduction informed. Examples. What might your patient come up with when they're asked how they might want to change? Well, for people who inject drugs, some examples are maybe well, actually, very most likely they are not ready to stop injecting, but they probably are interested in staying healthy as much as they can, and maybe they're interested in injecting more safely. There are ways to inject more safely. Maybe they don't want to share needles as often as they do. Maybe they're willing to at least just carry Narcan so they can give it to a friend. So if they suffer an overdose, it can be counteracted. Maybe they are willing to use less. Maybe they are willing to abstain. But it's a series of options. Maybe they're willing to accept medication like buprenorphine for their treatment. Maybe they just want to learn, they're ready to learn better care of their abscesses that they get from injecting. Or maybe they're just not willing to do anything except for continuing to come and see you, just continuing to get primary care. And if that happens, don't discount that. Pat yourself on the back, because this population does not engage in healthcare like they should. This is why overdoses are so preventable. Blood and skin infections are so preventable. And by getting regular health care, that's how you prevent those things. So if you have a patient who's not willing to change their substance use, but they're willing to come back and see you, you've achieved something great. Pat yourself on the back. Here's examples, by the way, for patients who, and this is where you can reach out to your local harm reduction coalition or agency that does needle exchange if you have one, but or you can look this up yourself. But here's an example of how someone who's interested in injecting more safely could do so based on where they inject. And by the way, if you think providers already know this, this is a survey of infectious disease physicians. I couldn't find primary care ones, and it just asked them, how comfortable are you assessing your patient's injection practices and offering counseling? As you can see, a minority of them are comfortable with it. Small minority have ever prescribed Narcan. So even with folks who specialize in treating the morbidity associated with injection drug use, HIV and Hep C, most of them do not practice harm reduction very much. They're not comfortable with it. So there's obviously room for improvement here. How about if someone has an alcohol use disorder? Well, maybe they're not ready to stop drinking. They're not ready to go to treatment, but they are willing to maybe count their drinks. Might be a way to reduce the chances that they pass out or drink too much. Maybe they can eat while they drink or beforehand. Maybe they can mix their alcoholic beverages or space them out and drink ones that do not have alcohol. And of course, maybe they are ready for treatment. Maybe they just avoid mixing drugs with alcohol. So there's lots of drinking in a safe place. There's lots of ways people can reduce their harmful use beyond just quitting entirely. And if they engage in this, remember, I'll jump to the slide here, if we reduce harm as a patient, or we help our patients reduce harm, they have a better chance that their quality of life improves. If someone's quality of life improves, they are more likely to get on a pathway to recovery. So don't discount, again, some kind of small change that feels small to you as a provider. It could mean a big step to getting these folks to recovery. A couple other things here. So goals should be well defined if you can. They should focus on reducing harm. They should be doable in some sort of time frame, and they should, of course, come from your patient. Sometimes your patients may have really no idea of a goal. You may ask them what they're willing to do about their substance use, and they respond by saying, I don't know. It's perfectly fine to ask your patient permission to offer some ideas. Saying something like, if it's okay with you, I have some ideas and some other patients have chosen as goals to reduce their harm. Is it okay if I share them? And the patient says yes, then you can offer some things. But they need to remain patient driven. Sometimes patients, they just say something general like, well, I just want to be healthier. That's a pretty large goal and it's kind of abstract. So you might work with a patient to come up with some steps, that large goal of living healthier, by asking, what would be the first step towards living healthier? So helping them identify something concrete, well-defined, doable in a time frame. So back to enhanced motivation, we've elicited a goal, we've asked them what they want to do, it comes from them, great. And then, the last step is this readiness ruler is a great tool because if you don't have a lot of time, it's a great tool to gauge someone's readiness to change, and it can enhance their motivation change. And if you're not familiar with the readiness ruler, on a scale of 0 to 10, with 0 being you're not ready at all to reach this goal, and 10 being really ready, where would you put yourself? And if someone says, for example, 5, and you follow up with a question, why not a lower number? Why did you choose something as high as a 5? That gets the patient to think about their motivation to change, and when they verbalize it, there's research that shows verbalizing motivation to change is shown to enhance, to increase our motivation to change. So even if this seems tacky at this point, if you're tired of using the readiness ruler, it still is a good tool when you don't have a lot of time to gauge your patient's motivation to change and to enhance it. And remember, just some traps when you're a healthcare provider. We are focused on sometimes fixing a patient, like a car mechanic wants to fix a car with a problem. But if we take that approach, we're making it really about ourselves and not about the patient. So if you find yourselves doing these things, you are backing away from a harm reduction approach or a patient-driven approach. Of course, patients feel these adjectives when they are the recipients of that. So that's what we want to avoid. So back to our model here, brief negotiate interview, enhanced motivation, that's good. Negotiate plan, so the last step, I would change the name of that too. Maybe it's not a big deal just to change the name, but it reinforces how we approach this. I would change it to identify plan. I don't know what negotiate means, because if a patient has a plan of harm reduction to change their behavior, why would they need to negotiate that with the provider? Maybe I just don't understand what that means, but I think it's more accurate to say, let the patient identify a plan. And this all comes from the original model, and it's all good. So if the patient it sounds ready for the plan, like maybe they're above a 5 on the readiness ruler, you should ask them, so what would that look like for you? What would carrying out a plan to achieve this look like for you? So people are more likely to carry out a plan of change when it's a plan they came up with. Affirm the rating. It sounds great. I'm really glad to hear you're willing to do this. I'd like to check in next time in a couple of weeks to see how it's going. So ask to schedule follow-up. And what is follow-up with someone with a substance use disorder? What is follow-up when we're being harm reduction informed? And this comes from Susan Collins. It means we are collaboratively tracking changes or metrics that the patient selects. So we might not be meeting our funding goals if we're a grantee, if the patient isn't going to treatment. That's the funder problem. If we're patient-centered here, we are working with the patient to see what they think their metrics should be. It could be any of those things I mentioned in a couple of slides about using more safely. It could be finding housing. It could be disclosing to their spouse for the first time their substance use disorder. It could just be coming up and following up on their diabetes. Whatever it is, if it's something, a step in a harm reduction direction, that's what you can track. And whenever they come back in, their harm reduction goals may change. So it's always good to check in with them next time. Is there anything else you want to change about their substance use? You inject more safely now. Are you, what else? And they might come up with, well, I'm willing to go to needle exchange to clean needles, or I'm willing to try checking into treatment for a period of time to see what it's like. It could be anything, but always check in with them what their latest goals might be, and then continue to discuss safer use strategies. So this is the role of follow-up. So summarizing here, this is what the 4 steps of a brief intervention look like that is harm reduction informed. This is my proposal. I am considering making this, revising the pocket cards we have on the SBIRT Oregon website to use this kind of language. It helps as a provider who's new to doing brief interventions to have some sort of guide or pocket guide, and this could be put on a card. Ultimately, at the end, what is our philosophy? We defer to the patient's wisdom, right? So the more responsibility or autonomy a patient feels, and if they feel you respect them and the choices they make, those are the same qualities that are required to forge their own pathway to recovery. So just because they aren't ready to accept abstinence or treatment immediately or within a few weeks doesn't mean that they don't have the qualities to eventually get there if you give them the room and help them achieve goals that reduce their harm first. So by taking a harm reduction approach, we are reinforcing a patient's autonomy, self-respect, and self-efficacy. We defer to their wisdom. They know the context of their lives, not us. If you heard of the OR skills, I'm not going to go through them, but just so you know, they are harm reduction approved. They fit in the harm reduction model. They're great. So asking open-ended questions, affirming the patient's motivation or anything positive they've done to change. Of course, reflective listening, summarizing what they say. These are all great tools to use in harm reduction. And here's an example, some text here of reflections and open-ended questions. So our last thing I'm going to do today, and I will finish up quickly here, is the referral to treatment, and I'll be quick because basically it should be done away with. I mean, the traditional model is that we should deliver it through a brief intervention, and that is good. We just don't say, I recommend you go to treatment, please go. We do it through a brief intervention that explores the patient's motivation to do so, and that's good. That makes it patient-centered, but the traditional SBIRT model makes the referral come from the clinician, and that's not HR reform. We should only explore goals that come from the patient. So if the patient's ready, curious, or wants to try treatment, sure, then we could, I guess, make a formal referral, but that's not going to be the case because of this famous statistic. So this comes from SAMHSA, or I believe it does, Parkley Associates. So 95% of people have a substance use disorder, or what SAMHSA defines as, quote, need treatment, their definition, don't believe they need treatment themselves. That is a huge statistic, and it totally belies the traditional SBIRT model. Because why would we refer someone to treatment if there's a 95% chance they don't even believe they need treatment? It's a waste of our time. It implies judgment. It makes the patient feel more trapped. It's not evidence-based, as we saw earlier in this presentation. So it's just not an approach worth taking. There's all sorts of barriers to why someone might need treatment, even if they think they do need treatment. If they're in that lucky 5%, there's so many barriers to treatment that get in the way. So maybe they are scared of going through withdrawal. They're scared of being publicly outed as someone with a substance use disorder. They don't have transportation. As you can see, there's lots of barriers, more reasons why they may not do it. And I want to throw out here a really disappointing metric, a HEDIS measure that I was just made aware of, that is going to be adopted in Oregon, I heard, as a CCO incentive measure next year. It comes from the NCQA, and it is a metric for referral to treatment. It wants patients who have a new episode of dependence, it's an outdated word, to initiate treatment within 14 days. And even if that's medication-assisted treatment, any kind of treatment, 14 days. And then it wants these patients to have 2 or more additional services within 34 days. This is awful. It totally belies how we understand people with substance use disorders behave and how they forge pathways to treatment. It is the opposite of harm reduction. I don't know, I guess I'm really criticizing the HEDIS measure here, but I don't know who advised them on this. And it encourages kind of a cynicism among providers, I think, who are clicking ever more boxes in the EHR, digging around their EHR and clicking boxes to meet all sorts of performance metrics. And if the performance metrics aren't wise and don't come from a good place, it just encourages the cynicism providers already have on why they're doing this in the first place. So evidence that policymakers are not always making the right decisions. So what should we do instead? Instead of referral to treatment, just continue to help your patient. They follow up, continue to track with them, elicit their harm reduction goals, discuss strategies. That's how we work with patients and follow up. I'm not the only one who wants to do away with referral to treatment. There's a new change guide out from the National Council for Behavioral Health, made of leading researchers in the field, and they say instead of referral to treatment, just rename it management and offer them types of options. And they propose a metric that if there were to be a metric for referral to treatment, I would agree with this one. I support this. Within 90 days, just a follow-up visit. Someone engages in care in any capacity in 90 days, great. That is an accomplishment. I could support that metric. So I'm not the only one proposing we do away with referral to treatment or redefining it. These folks are too. So takeaways, this is the last slide here. We can help people with SUDs by changing SBIRT a little bit, by being mindful of stigma, adopting a harm reduction philosophy, tweaking the brief intervention in a way that's harm reduction informed, and replacing or totally reforming the referral to treatment as we know it. That's my proposal, and I'm not the only one who's proposing this. And that is it. I'm sorry I didn't leave a whole lot of time, but if anyone's still sticking around, I'm happy to take questions and comments.
Hi, Jim. So, yeah, there were quite a few questions and comments. I'm just going to start in the order that they came in. So, at the beginning, when you're talking about the VA study, someone had asked, receiving additional services may not tell the whole story. Was drinking and drug use less in the one group? Perhaps they took advantage of the advice and self change may have kicked in.
Yeah, good comment here. I think there's always more to the story when we look at the data and analyze it. I think, though, the mere fact that a brief intervention was associated with a lower likelihood of receiving special treatment with such a large, rigorous study is enough in and of itself to really raise alarm bells. But thanks for the comment.
Okay. The next one is, are there any successful interventions to reduce stigma among healthcare providers?
Yeah, there was one slide in my presentation that refers to, it has been studied, there's a couple studies out there, and it has measured reduced stigma from providers if they attend a training that explores factors that can mitigate stigma. So training and education can be effective. The other factors associated with less stigma are a prior history with working with these patients and prior education and training on addiction medicine.
Great. The next one is it possible to believe in addiction as a chronic brain disease and implement harm reduction within treatment providers and medical practices?
Yeah, I think so. I think as long as you're mindful of not conveying that disease model to the patient, you're okay. It's not important, I think, to convey to the patient that our current understanding of a substance use disorder is that it's a brain disease. I think what's important is to tell the patient, I'm hearing from you that you are experiencing some negative consequences from your drinking and that you're curious about doing it in a safer way or somehow changing a behavior that would reduce the harm. That's what's important. If you yourself believe in the disease model because it helps you understand substance use, I think that's fine. Just be careful about conveying that to someone. Susan Collins herself tells an anecdote about how she was told by a provider a few years ago that she's probably an alcoholic. That was a term that they used back then. And she said it felt very stigmatizing, and that she replied back by saying, well, the science keeps changing and we don't really know if I can be defined that way by my behavior. And so It doesn't help the patient to convey that model, but if you believe in that model yourself, I think you can still deliver harm reduction to a patient.
Perfect. How does harm reduction transfer to speaking with adolescents versus advising abstinence to ensure that they do not assume that you're giving them the okay to use as long as they are cutting back?
Yeah, I've asked the Harm Reduction Coalition about this too, and and harm reduction advocates think this is great to use with adolescents because if there's anyone who prizes their autonomy in self-decision making, it's adolescents. So this is definitely an approach to take, and I know that the evidence is stronger with drug use with adolescents on its effects, and we may be uncomfortable with not just flat out prescribing abstinence with an adolescent. But what we can do is be honest about our concern. I'm concerned because we know the medical literature says a teenager who smokes pot is less likely to do well in school, more likely to be injured or have an STD. I'm concerned about that. Is there anything about your use that you would like to change? I would still stick with the harm reduction. We had evidence that advising an adolescent to abstain from their use led to less use or less harm. That would be one thing, but we don't, of course. That doesn't seem to work. So just like we use motivational interviewing with adolescents, we should also use harm reduction with adolescents too.
Perfect. What is an example of a way to redefine referral to treatment?
Yeah, my last slide there, there's a change guide put out by the National Council on Behavioral Health, and they recommend instead of saying referral to treatment, to look at it as management of a substance use disorder. So I have a patient who probably has a substance use disorder. Instead of referring to the treatment, I want to have them keep coming back for follow-up. And you can call that management if you want. And when they come back for follow-up, I want to check in with them on how their plan of harm reduction is going, if they have one, to ask them if they have any new ideas or new goals for harm reduction. And then what was my last goal? I'll just go to the slide. So this is what I propose to replace referral to treatment with. Recognize what your patient wants to change, collaborate with them on tracking that. Elicit with them if they have any new goals with harm reduction, and then continue to discuss safer use strategies. So abstinence is always an option as part of harm reduction goals, but it is never a referral, it's never a prescription. This is what I would replace referral to treatment with.
Okay, thank you. That was the end of the questions, but there were just a few comments that I'll read through quickly. The first comment was, I see a lot of patients that also have mental health issues, and when they go to the methadone clinic, the therapist only talks to them about their addiction and not their depression or anxiety. I have to get them another therapist to deal with these issues, and it makes their recovery a bit easier. Um, the
Thank
next
you.
The next comment is, I see many people who state they are no longer a substance abuser giving up alcohol and drugs, yet they say that they utilize THC every day. So, how are we now looking at that since it's legal in many states?
People have their own definitions of what it means to be sober or in recovery, whether it's cannabis or like a medication for opioid use disorder. Some people consider the day they first accepted buprenorphine as the day they became sober. For other people, it's the day they tapered off buprenorphine as the day they became sober. It's really up to the patient to define what it means to them, what abstinence means.
Right. And the last two comments, the SAMHSA stat conflicts with syringe exchange surveys in my state. The majority of our syringe exchange patients do want help, but don't like the term treatment. And the
Yeah,
last comment, oh, go ahead.
sorry, I was just going to respond. Yeah, that's probably a selective population that is showing up to needle exchange. They are actively trying to reduce their harm. Um, that stat that I show that 95% of people who have substance use disorders don't feel like they need treatment, that is a general huge population sample. So probably the folks that show up at needle exchange are a special group. and they are to be commended because they're being proactive in reducing their harm.
Okay, and the last one is this was very helpful. Thank you for presenting the information and reaffirming our hard work at non judgmentally providing a place to talk openly about substance use. My college students greatly appreciate our open conversations that do not stigmatize. Do you have any suggestions that would maximize benefits with this population?
The population of college
The
students, do
college
you think?
students,
Oh,
yes.
yeah. Yeah, I would say go to the Harm Reduction Coalition websites. They have great resources on downloading training curriculum slides that are already produced and designed and ready to go. They have great videos to watch. Same with the Susan Collins Harm Reduction Treatment Center website. Most of her trainings are on YouTube. They're an hour long. So there's great resources on there and becoming better informed about harm reduction.
Great. We're now going to close the questions portion of today's webinar. So thank you all for your great questions, and thank you again, Jim, for such a great webinar. At this time, I would like to go over our evaluation and CEU instructions. You'll receive a few emails from us following the webinar. The first email will include a link to the evaluation. The second email you will receive includes step-by-step instructions on how to access your certificates via your MyIRETA account. Our evaluators are pleased to collect feedback from all event participants. Completion of this evaluation is critical to continue to provide quality education and materials. Your participation is appreciated, and the evaluation should take no more than 2 minutes of your time. Certificates may take up to 48 hours to appear in your profile, so again, we ask for your patience. Another email will be sent around to all registrants early next week and will include a link to the recording of the webinar as well as a PDF version of the presentation slides. Again, we want to thank you for your participation, and if you have any questions, please email us at info@ireta.org. Thanks, everyone.